Hello, everyone, and welcome to the first Sleep Grand Round sponsored by the American Academy of Sleep Medicine Foundation. I am Vanessa Gonzalez, the Director of Grant Programs for the ASM Foundation. Next slide. Thank you. So for those that are not familiar with the ASM Foundation, it is the philanthropic organization for the American Academy of Sleep Medicine. So for 25 years, the foundation has been the leading organization helping investigators, community leaders, and clinicians address the challenges of the evolving field of sleep. The programs of the ASM Foundation support career development, high impact research projects, and community programs that are championing a bright future in sleep health. Today, we have Dr. Plante from the University of Wisconsin-Madison joining us to discuss novel diagnostic and therapeutic strategies for hypersomnolence. Before I introduce Dr. Plante, I'd like to remind you that your audio is muted and your video is off. We encourage you to include any questions on this topic for the speaker in the Q&A section of the Zoom platform. And also, please refrain from using your cell phone or a pager while you're on this webinar. This webinar is being recorded and will be shared with everyone that is registered for the webinar. Next slide, please. Oh, perfect, you already have it up. So in accordance with the updated Accreditation Council for Continuing Medical Education Standards for commercial support, the ASM has implemented a process requiring each speaker to disclose and resolve all conflicts of interest with any commercial entity. We have reviewed the disclosures and resolutions and believe that the submitted citations comply with the ACCME standards. The disclosures and resolutions provided by the speaker are included in the slide presentations for the attendees' information. Next slide, please. And now allow me to introduce our speaker for today. So Dr. David Plante is a clinician scientist whose research focuses on central nervous system disorders of hypersomnolence, as well as the interface of sleep and neuropsychiatric disorders. He is currently an associate professor of psychiatry at the University of Wisconsin-Madison, where he also serves as the medical director of the Wisconsin Institute for Sleep and Consciousness and Wisconsin Sleep as the program director of the Clinical Sleep Medicine Fellowship. Dr. Plante is also a recipient of multiple ASM Foundation research grants, with his most recent being a 2020 strategic research grant for his project titled The Role of Epigenetic Modification of PAX8 in Hypersomnia. And the goal of this project is to determine whether epigenetic modification of PAX8 differs between people with idiopathic hypersomnia and people who are healthy, and whether epigenetic modification of PAX8 is a stage or trait marker for hypersomnia. So thank you for joining us today, Dr. Plante. I'm going to pass the mic over to you.
Well, thank you so much. I'm going to share my screen here to get to my slides. So does that look okay?
Yes.
Excellent. So thank you very much for the invitation and the warm introduction. So I'm very pleased to give today's talk on novel diagnostic and therapeutic strategies for hypersomnolence. The work that I'll be presenting here is actually funded by a couple of other generous awards from the ASM Foundation when I was early on in my career, and I hope that you find the information very interesting and applicable. These are relevant conflicts of interest have been resolved. And this is the accreditation statement for the ACGME. So in terms of the overall objectives for today's talk, first we'll kind of briefly go through the main diagnostic criteria for central nervous system disorders of hypersomnolence, focusing primarily on type 1 and type 2 narcolepsy, as well as idiopathic hypersomnia, recognizing that a lot of people in the audience may not necessarily be familiar with them, but it'll be a relatively quick overview. And it'll set the stage for us to think about some of the diagnostic criteria and the tools that we use to identify and categorize persons with hypersomnolence. So we'll also review ancillary measures of hypersomnolence, so other ways besides the typical tools we use in clinical sleep medicine, and how they may, ultimately impact patient evaluation. And then we'll also try to highlight and describe situations where some of our nosology, so how we categorize various sleep disorders, may not sort of match up very well with our clinical practice and potentially be problematic for both patients and providers. So let's briefly talk about the ICSD-3. Anytime you talk about nosology, sometimes it can get a little bit dry. So I'll try to hit the highlights. So the ICSD-3 has recently gone through a text revision. for those of you who aren't aware, and I'll highlight the relevant changes, at least on a high level here, talking about type 1 narcolepsy, type 2 narcolepsy, and idiopathic hypersomnia. So this is how we make a diagnosis of all of these central nervous system disorders of hypersomnolence. So the first thing that you have to have is you have to be sleepy, right? You have to have a complaint of daytime sleepiness to be considered in this sort of broad category of disorders. Now, we break down these different diagnoses based on sort of both subjective report and also objective findings. So for narcolepsy type 1, you have to have one of two objective findings. So you can either have the complaint of cataplexy or loss of muscle tone in response to emotional stimuli, classically laughter or mirth, and it's described in detail in the manual, so I won't go into too much detail here. But then you also have to have typical findings on an overnight sleep study and multiple sleep latency test, where you have a mean sleep latency below 8 minutes on the MSLT and 2 or more SOREMs or sleep onset REM periods, or there's been a slight change. You can have a nocturnal SOREM on the overnight polysomnogram because that has relatively high specificity in the context of having cataplexy as well. The alternative way you can diagnose narcolepsy type 1 is to do a lumbar puncture and measure the cerebrospinal fluid hypocretin, or also called orexin level, directly. And if it's low, less than 110 picograms per milliliter, then you can make the diagnosis that way as well without using in-lab testing. Narcolepsy type 2 is a little bit different, but it's very similar in the sense that we typically get a multiple sleep latency test and a polysomnogram. Typically, you would see the same MSLT findings as you would in type 1 narcolepsy, where you have a mean sleep latency at or below 8 minutes, 2 or more sleep onset REM periods, inclusive of the overnight sleep study. So if you have a nocturnal sleep onset REM period, that can be counted towards the overall tally of sleep onset REM periods you would need to have. To have narcolepsy type 2, though, you should not have a report or complaint of cataplexy. And also, if you happen to obtain a lumbar puncture on these individuals, their CSF hypocretin should be in the normal range. In idiopathic hypersomnia, similarly, should not have a report of cataplexy. The sleep study findings, as well as the multiple sleep latency test, should not be consistent with a diagnosis of type 1 or type 2 narcolepsy. So there are a couple of objective findings that we're looking for to diagnose idiopathic hypersomnia. The first is on the MSLT or multiple sleep latency test, having a mean sleep latency below 8 minutes with 1 or fewer sleep onset REM periods, again, including the overnight polysomnogram. Or you can also make the diagnosis with the objective finding of excessive sleep duration, which we'll talk a little bit more later in the talk. In this case, greater than 11 hours, either on an extended duration polysomnogram, so one done over like a 24-hour period, for example, or potentially actigraphy as well. Now, the astute observer will also note that I have an asterisk by the objective findings because there's also a very small clause in the ICSD-3 that says you can make the diagnosis of idiopathic hypersomnia based on clinical grounds, even if you don't have these objective findings, if you feel that that's really what the patient has. So it's a little bit of a tricky spot where we don't sometimes always have good objective findings when we're trying to decide, does somebody have idiopathic hypersomnia or not? And then broadly speaking, these signs and symptoms really shouldn't be due to some other sort of explainable disorder, medication, or substance. So there's a lot of other disorders in the central nervous system. Hypersomnia section of the ICSD-3, which I won't go into in any specific detail, but suffice it to say, there's lots of different disorders that are associated with daytime sleepiness, both in this section in the ICSD-3, and then also broadly throughout sort of our practice in sleep disorders. So many sleep disorders will present with complaints of excessive daytime sleepiness. So I think that leads us nicely into a discussion about what excessive daytime sleepiness is. So I can't see any of you because of the format of the Zoom chat and the fact that we're connected, virtually. But if I went around the room and everyone attending today and I said, well, have you ever been sleepy during the day? I think most people would say yes, right? This is a universal experience to be sleepy at some point in time, maybe not chronically or all the time, but sleepiness impacts all of us. But if I asked you to describe how you experience your sleepiness, my guess is that people would tell me different things, right? So some people might say, well, I have trouble staying awake. Some people might say that I just fall asleep really easily, or sleepiness is falling asleep easy to me. Some people may say they just kind of feel drowsy. They sit there and they just can't stay awake. They feel drowsy or sleepy. And then other people may have more somatic descriptions where they may say, I just feel like my eyes are getting really heavy, like my eyes are burning. I can't stay awake. I feel sleepy. So there's lots of ways that we describe this phenomenon that's really quite universal. How we measure daytime sleepiness is also tricky. So broadly speaking, we can measure sleepiness either subjectively or objectively. So many people in the audience are probably aware of the Epworth Sleepiness Scale. I won't go into detail. It's a very common subjective description of how likely we are to doze off or fall asleep in 8 real or imagined situations. And you simply add up the sum scored 0 to 3 on those 8 questions, and you get a sense of how sleepy someone is. Now that's used very commonly in sleep medicine. It's almost universal. The multiple sleep latency test, however, is really the main objective measurement we use in sleep medicine to quantify how sleepy someone is. And you can kind of see that through our nosology. It's very important in thinking about disorders like narcolepsy and idiopathic hypersomnia as well. So just to make sure we're all on the same page, because I know some people in the audience may not be that familiar with the multiple sleep latency test, I want to highlight sort of what it is. So it's a very basic or straightforward paradigm that was actually designed and developed to sort of try to quantify the effects of sleep restriction or sleep deprivation. And the protocol has been modified over time, really has become a key test for identifying central nervous system disorders of hypersomnolence like narcolepsy. So it consists of 4 to 5 nap opportunities spaced roughly 2 hours apart. And it should occur after a night of sleep, ideally 6 hours, but in reality, more than that is better. And what you're doing is you're basically putting a patient or a research participant into bed and saying, I'm going to turn off the lights. I'd like you to try to fall asleep. And you're measuring how long it takes to fall asleep from lights off to that first epoch of sleep. That's what we call sleep latency. And then we're also measuring the time from sleep onset to the first epoch of REM sleep, and that's called the REM latency. And the REM latency is not the main measure we're looking at. It's whether or not you go into REM sleep on naps, because oftentimes you do not. And the way the protocol plays itself out is if someone doesn't fall asleep in 20 minutes on that nap opportunity, that nap opportunity is ended, and you sort of wait for the next one coming down the pike. Or if people do fall asleep within that 20 minutes, then they're given an additional 15 minutes to see if they go into REM sleep or have a sleep onset REM period. So that's basically how the multiple sleep latency test works. And the multiple sleep latency test, as you kind of learn from kind of thinking about the ICSD-3 criteria, is really key to making diagnoses in the CNS hypersomnia section, especially around narcolepsy. And it turns out the MSLT is actually a really nice and good test for helping to confirm suspected type 1 narcolepsy. It's not perfect, but it does a pretty darn good job. The problem is it has some real limitations when you move outside of type 1 narcolepsy. So disorders like type 2 narcolepsy, and especially idiopathic hypersomnia, really run into a lot of retest reliability issues with the MSLT. So what that means is we're using this test very frequently to help delineate these disorders, but it may be good at ruling in type 1 narcolepsy, but maybe not so great at ruling in these other disorders the way that we have things set up. Now, there could be a lot of reasons for this. One of them that we haven't really talked about yet, which I think you'll hopefully appreciate by the end of today's talk, is that also when we're talking about hypersomnolence, sort of broadly speaking, it's a multifaceted phenomenon. So what I mean by that is the MSLT fundamentally measures our ability to fall asleep under soporific conditions or sleep propensity. So when we allow someone to fall asleep and we ask them to try to fall asleep, can they do it? However, there's other aspects of hypersomnolence that are not captured by the MSLT. So a classic example would be the ability to stay awake. So in sleep medicine, we also have a paradigm called the maintenance of wakefulness test. It's very similar in a lot of ways to the MSLT, but the instructions are different. We tell the patient to try to stay awake. And it turns out that people can have discrepant values on the MSLT and the MWT, and they're not all that closely related, even though they're very similar paradigms. Also things like excessive sleep duration, which is really important in the context of idiopathic hypersomnia, and we'll talk about more later on in the talk, can be a really important measure of hypersomnolence, sort of broadly speaking, and quite impairing for folks. There are other aspects like psychomotor vigilance, which we'll talk about in a minute, and also drowsiness. And all of these different measures aren't necessarily captured by the MSLT itself. They're all associated with complaints of hypersomnolence, but also not only do they not correlate that well with the MSLT, they oftentimes don't correlate all that well with each other. So it's a real challenge to actually measure or quantify hypersomnolence, and the MSLT is really only capturing one aspect of that. So this is a non-exhaustive list of all the different ways that we could think about measuring hypersomnolence, again, sort of dividing the world into objective tests and subjective tests. So we've already talked a little bit about the MSLT and alluded to the MWT. I'd like to take a moment just to talk about reaction time task measures, for example, and how they may be related to hypersomnolence. So many folks are probably familiar with the psychomotor vigilance task. If you're not, I'll give you a very quick overview. So this is a very common measure of neurobehavioral vigilance. It's used not so much in clinical practice, but it's been used widely in sleep research for a number of years since it was developed by Dr. Dinges at the University of Pennsylvania, largely as a tool to measure response or impact of sleep restriction. What's really wonderful about the task is it's very simple. So basically what you ask a patient or a participant to do is to look at a visual display and respond to a counter that comes up intermittently on a random interval. And that counter is counting upwards in milliseconds. And your job as the respondent is to basically press the button or the space bar as quickly as you can when you see those numbers start. And that's a measure of your reaction time. So it gives you real-time feedback. And you're supposed to respond as quickly as you can while avoiding false starts, right? So you shouldn't try to guess when the number is going to come up, because that too is not correct. And it turns out that a lot of these different measures, that they're very much correlated with each other, but things like your reaction time and also the number of lapses. So if you fail to respond within 500 milliseconds, those are associated with subjective complaints of daytime sleepiness. So I want to kind of highlight, because I'm a clinician scientist and I love seeing patients, they sort of teach me more than anything that I would do in the lab, I think, a lot of times, and give me really important insights into sort of the things that we should be thinking about. I'm going to present this as a real case. I mean, obviously names and things have been changed to protect people and maintain confidentiality, but we'll call this case, what do you mean I'm not sleepy? Okay. So I think this kind of presentation is very common in sleep medicine. So this is a 20-year-old woman who presented to sleep clinic, basically with a history of long-standing daytime sleepiness and also a long sleep requirement dating back to middle school. There was no specific trigger or onset. She's basically stated that without an alarm, she might sleep 10 to 12 hours per night, and then also take a extended nap in the afternoon. Her Epworth was 14, so she was sleepy per subjective report. She didn't have any report of cataplexy or sleep paralysis or hypnagogic or hypnopompic hallucinations that might point you towards suspicion for narcolepsy. Her past medical history was relatively unremarkable, except that she had a history of anxiety that she wasn't on any medications when we saw her, and she had no history of depression or significant anhedonia. She was slightly overweight, but otherwise her physical exam was very much unremarkable. So she ended up getting referred for a very sort of typical workup, I think, in many sleep labs for suspected central nervous system disorders of hypersomnolence. So in our lab, we try to get actigraphy on people whenever we can, and we try to do the actigraphy before they come into the sleep lab. So she had actigraphy followed by an overnight sleep study and a multiple sleep latency test. In our lab, we do our best to let people sleep what we call ad libitum, so not wake them up at a prescribed time for their MSLT, which we can talk about a little bit later. That's challenging, but we try to make sure that people are well saturated in terms of their sleep time. And what we found was on her actigraphy, she actually was sleeping more than typical. So her sleep time, as estimated by the device, was 9.25 hours thereabouts. She was actually spending a lot of time in bed. Her sleep efficiency was only 73%, which is she was in bed trying to sleep 12 or more hours in terms of rest intervals. And she was napping 6 out of 14 days. Her overnight sleep study didn't reveal any sleep fragmenting pathology like sleep apnea or periodic limb movements that would sort of cause her symptoms. In the lab, she didn't quite sleep quite as long as she would at home, and her sleep efficiency was a little bit higher, but otherwise was relatively unremarkable. And importantly, she also estimated her sleep time in the lab accurately. So she said that she thought that she slept basically as much as she did, just over 6 hours. So a little bit different than at home. Regardless, she met the protocol to do the MSLT, and she did sleep on her naps, but only on 3 out of 5 naps. And the mean sleep latency was 13.4 minutes with a range of 6.5 to 20. And she didn't have any sleep onset REM periods, either on her MSLT or her overnight study. So in summary, kind of a relatively negative evaluation per the ICSD-3 objective criteria. So I guess the question that I'd pose to you that I'd like you to think about, even though we can't sort of openly chat right now while I'm talking, maybe in the Q&A section this will come up, is what do you think you would diagnose this patient with, right? So there's a lot of different possibilities, and I'm not trying to be dogmatic. I just want people to think, would you say, okay, maybe they have idiopathic hypersomnia because clinically they have very similar complaints to what we see in IH. I don't see any other medical or psychiatric causes of their problems. Even though they didn't meet objective criteria, they're still sleepy. Maybe they should be treated or at least diagnosed with IH. Some people might say, well, they don't meet ICSD-3 criteria for idiopathic hypersomnia, but they do meet what's called the DSM-5 criteria for hypersomnolence disorder. So I didn't go into it just for sake of time today, but in psychiatry and psychology, there's the Diagnostic and Statistical Manual, which is another nosology, and they have a similar disorder to idiopathic hypersomnia, but it doesn't have the same sort of very stringent objective criteria to make the diagnosis. There are some suggestive findings like sleep time greater than 9 hours, for example, which we did see on actigraphy. So she might better sort of fit into that diagnostic category, but we don't use that one per se in sleep medicine. Is this some kind of insomnia variant? You know, she didn't have great sleep efficiency out in the field, but a variant in the sense that she also had long sleep duration. It's hard to know. Or is there some other possibility that we're missing, which is always quite possible, but as far as we could tell, there wasn't anything on her medical or psychiatric workup. So with you thinking about like what you'd tell this patient or maybe what diagnosis you'd give, I also want to sort of add an additional layer of information and see if that might change your thinking. So this was a patient who was also in a larger sleep study, part of this ASM Foundation funded study, which I'll show you the overall results in a little bit, but she had her in the middle of her sort of time in the sleep lab. We also collected additional measures, including the psychomotor vigilance task. We did it in the morning and the afternoon. And what we found in this patient was she actually had a lot of lapses. So on average, between the two time points, she had 8 lapses per 10-minute trial, which is more than you would expect. There's not great population-based data or estimates on the PVT, but what we know from data from the Wisconsin Sleep Cohort study is that more than about 4.8 lapses sort of puts you into a higher range than you'd like 2 standard deviations outside of normal. So something's amiss. And then also her reaction time, just to kind of sort of give you a sense of where she fits in with other persons with hypersomnolence. So compared to people with idiopathic hypersomnia objectively diagnosed in the larger protocol, she had quite a slow reaction time as well. So there seems to be some impairment in the domain of psychomotor vigilance for this patient that we're not capturing, where they sort of not in this research study. So we've talked a little bit about ancillary tests like reaction time. Now I want to talk a little bit about another task that we employed or have used in our research, which is infrared pupillometry. So for those of you who aren't familiar with pupillometry, I'll give a very sort of brief summary of it. What it is I think, a very cool measure of non-EEG based measure of drowsiness, right? So we don't have to use EEG. Here we're using a pupillary measurement to get a sense of how drowsy someone is. The way that it works is it measures spontaneous changes in the pupil diameter that occur in constant conditions, so in darkness. So normally our pupil will dilate and constrict in response to the amount of ambient light. But if you hold that condition constant, the pupil will change or not change depending on your level of drowsiness. The way that it's quantified is it measures fatigue waves, and I'll show you what that means on the next slide. And then while we don't know exactly sort of all of the factors that go into sort of pupillometry findings, there is a pretty well-described pathway related to pupillary constriction and dilation. And at the center of it, we're involved in is the locus coeruleus, which is a really important component of the ascending arousal mechanism, is very important in wakefulness as well. So to kind of give you a sense of what pupillometry does, so this is the eye, right, measured under an infrared camera. You can see the pupil is that dark area, and the diameter is just that line right across. It's a circle, so it's relatively straightforward and easy to measure. What happens is in pupillometry is you measure the diameter of this pupil, again, over time. Typically, this is an 11-minute task once people have acclimated to darkness. And all you're doing is measuring the diameter continuously. And if the pupil isn't constricting and dilating spontaneously, you will see a relatively straight line. That's what you see in that second panel in a healthy control, okay? In the top panel, this is a patient with narcolepsy. And what you see is, it's pretty wild when you actually see it, the pupil will just start to constrict and dilate spontaneously on its own until it'll get bigger and smaller on its own. And these are the fatigue waves, right? That's what they're called. And you can see in someone with narcolepsy, they may have quite a few of them. And then this is the general pathway, again, for pupillary constriction and dilation. And importantly, again, the locus coeruleus is right there in the middle of it. Now, there's lots of components to this pathway as well. The brain is a complex organ, but it's just something to keep in mind or food for thought. So the locus coeruleus may be involved or important here. Now, what's really fascinating to me is that pupillometry is not a new technology. It's actually been around and used in sleep medicine for a long, long time. It's never really caught on in clinical parlance per se, but it's been used from a research standpoint for quite some time. So this is a paper from over 50 years ago now at this point from Dr. Yas and colleagues at the Mayo Clinic, where they were using similar technologies or strategies to try to identify folks with narcolepsy. And they were actually using it to try to titrate medications. Now, just to be clear, I'm not recommending doing that necessarily because that hasn't been vetted to do, but certainly there does seem to be some, data that's been around for a long time that suggests this may be a really nice way to capture sleepiness in folks without using EEG. Now, we use a more modern system in our laboratory. So this is just kind of what the screen sort of look like. And in the upper right-hand panel, you'll see sort of what the typical setup may be condensed so you can see it all in the picture. But you're basically measuring with an infrared camera. The pupil's under darkness. You can either wear these goggles or just turn out all the lights so it's very dark in the room. And again, you're just measuring continuously over time. A really nice thing about this task too is the instructions are very basic for the participant. They don't have to do anything specifically except look straight ahead at a little sort of red dot that's there, a fixation point. So they really don't have to perform any tasks. It's just looking straight ahead. So it's relatively easy for folks to do. So that brings me to the second case I'll present, because I really like talking about cases to sort of bring this into a real world. We'll call this case, "What do you mean I'm not sleepy either?" Right? So you guys can probably guess a little bit about what we'll see. But so this is a 28-year-old woman, okay? She presented to the sleep center with complaints of fatigue, decreased concentration, and also falling asleep inappropriately for a number of years. It started for her around age 17 after a bout of mononucleosis. At the time of presentation, her Epworth sleepiness score was 20, so definitely in the pathologic range. She too had no complaints of cataplexy, sleep paralysis, or hypnagogic or hypnopompic hallucinations. She would describe naps, if she did take them, as being very unrefreshing to her. She did have a history of depression in the past, but she didn't feel like she was depressed or anhedonic. Her inventory for depressive symptomatology scale was 26, which puts her right at the kind of the cusp of, moderate sleep apnea, or sorry, not moderate sleep apnea, moderate depression. But she really did clearly deny depressed mood or anhedonia at the time we saw her. So largely sort of neurovegetative symptoms seem to be driving her score. Her BMI was quite normal, and it was only 19, and otherwise her physical exam was unremarkable. And she too wasn't on any central nervous system active medication. So this patient, we also did the same type of workup as we would for other folks, where we did actigraphy followed by PSG and MSLT, and here are her findings. So on actigraphy, she was sleeping a pretty normal amount each day, her just under 8 hours. Her sleep efficiency was good at 93%, at least estimated by the actigraph. And she napped 2 out of the 7 days of data that we had coming in before the sleep study. On her overnight sleep study, she didn't have any sleep apnea or significant periodic limb movements that would be causing her symptoms. Her sleep overnight was relatively unremarkable. She didn't have a sleep onset REM period. Her sleep efficiency was very similar to home at 92.4%, and she slept just over 8 hours. And then on her MSLT, she did sleep. She slept 4 out of 5 naps. Her mean sleep latency was 12.9 minutes, with a similar range to the last patient of 6.5 to 20 minutes. Interestingly, the shortest latency that she had was in her last nap. Sometimes we'll see on that last nap, people can't fall asleep, so that can maybe skew the mean sleep latency a bit, but that wasn't certainly the case here. And she too didn't have any sleep onset REM period. So same kind of question that I have for you, I want you to think about. What diagnosis would you give this person, right? She shows up, she's very sleepy. She says she's having trouble staying awake. And the sleep studies don't really reveal any sort of clear objective pathology. So would you give her a diagnosis of idiopathic hypersomnia based on the clinical symptoms? Would you, again, think about maybe sort of broadening the scope of your diagnostic criteria and using a different nosology like the DSM-5? Would you think of some other diagnosis? If there's something else going on, I don't know, but I think it's important that we think about how we would treat or manage this patient. But I'm also, again, going to give you a little bit of additional information to kind of chew on. So this participant also was participating in our research studies, sort of in tandem with her clinical workup. And she did infrared pupillometry in the morning, and she did infrared pupillometry in the afternoon, and we measured it. And in her case, her pupillary unrest index, which is sort of the way that we quantify or we can quantify the severity of those fatigue waves, so how much the pupil is opening and closing in constant conditions, was 13.6. Now, to put that in context, when this task or tool has been studied in a large population, sort of healthy population, 2 standard deviations from the mean is 9.8. So she's clearly well beyond that. She's clearly in the tail of what we would expect to see on this particular measure. So she's subjectively sleepy and objectively sleepy or drowsy, at least on this measure, but not what we are using currently in the scope of clinical practice. So we've talked about a couple of different tasks. We've talked about PBT in terms of reaction time tasks, in terms of ways we can measure hypersomnolence. We've talked about pupillometry. The last one I want to try to highlight, again, we don't have time to go through all of these, is sleep duration, because sleep duration becomes really, really important, especially for the identification of folks with idiopathic hypersomnia. So I'm not going to show you data from my lab. I'll show you some of that in just a little bit in terms of our clinical sleep lab. But I think this is a really great paper if you haven't looked at it or seen it before to think about. So this is from Isabelle Arneff's group in France, and they looked at consecutively recruited patients who met criteria for idiopathic hypersomnia. And in their lab, they do let people sleep sort of for extended durations as well. So they could identify persons with idiopathic hypersomnia who met criteria based on their MSLT findings. And they could also identify persons with idiopathic hypersomnia who met criteria based on sort of long sleep duration as objectively measured. And then what they were able to do is sort of divide the idiopathic hypersomnia group into 2, so those with and without long sleep, and kind of take a look at sort of what the patterns might be. And that's what you see in this graph here. So these 3 clusters of columns are basically the proportions of patients with a mean sleep latency below 8 minutes, the proportion of people sort of in an intermediate range of 8 to 10 minutes, so still not meeting ICSD-3 criteria, but suggestive, maybe they're kind of on the border. And then MSLT is greater than 10 minutes. And a couple of take-home points. One is that even healthy controls will have abnormal MSLTs below 8 minutes. Not a lot of them, but it does certainly come up from time to time. And then not surprisingly, in this study, all of the patients with objective idiopathic hypersomnia who did not have long sleep time, they had to meet the criteria. So all of those folks had a mean sleep latency below 8 minutes on the MSLT. But what's really important, and the take-home point from this is, look at the idiopathic hypersomnia patients who did have long sleep time and what their MSLT findings were in this. So broadly speaking, over 70% of patients with IH who have long sleep duration, so they slept more than 11 hours objectively, have a normal or a non-pathologic mean sleep latency. So the majority of folks with long sleep, we know, will not necessarily have an abnormal MSLT. So the problem is we oftentimes don't measure long sleep duration in our laboratory. So we're probably missing a lot of folks who have idiopathic hypersomnia, maybe sort of not diagnosing them appropriately. And then another sort of piece of food for thought for you in this study, and one of the things that I found fascinating, is these are 75 consecutive patients who met objective criteria for idiopathic hypersomnia. But they also excluded 30 patients who they diagnosed with IH clinically based on clinical grounds, but they didn't meet PSG MSLT criteria. So I think that highlights sort of how challenging some of the objective measures that we have are, especially in idiopathic hypersomnia. So that brings me sort of full circle to some of the data from our sleep lab and our research group, which oftentimes get blended together in sort of the research that I like to do. And this is a paper that it's published in the Journal of Clinical Sleep Medicine, so please feel free to take a look at it if you want to learn more details. But just a high-level summary, we consecutively recruited patients coming into the sleep lab who were getting PSG MSLTs, and we just asked if they were willing to participate in our research studies, where they basically fill out some additional questionnaires. And again, we measured the PVT in the morning and afternoon, and did infrared pupillometry in the morning and afternoon. And we had very high recruitment rates. These are usually people who are, I mean, these are not too difficult tasks, and they're a captive audience, and a lot of people are really, you'd be pleasantly surprised how many are willing to participate in research. And obviously we couldn't do this kind of work without them. But we were able to capture a lot of people over a couple of years getting sleep studies in our lab. And the study that we analyzed was after we had removed folks who had other clearly reasons for them to be sleepy, so sleep apnea or narcolepsy, medical conditions, et cetera. And then the final sample that we looked at sort of to try to understand these problems, or what we like to call unexplained hypersomnolence. So these are people who they either have idiopathic hypersomnia, or they have, they don't meet sort of diagnostic criteria objectively for IH, but have complaints of sleepiness. So there's 75 of those folks in total. And this is sort of what we found when we started to look at how these ancillary measures sort of play out over time. So to kind of orient you to this slide, the way that the three clusters work are very similar to the slide that I just showed you about the data from France. But these are different mean sleep latency values on the MSLT as far as where we might define objective pathology. So 5, 8, and 10. So in the middle is what we have typically clinically, at least per the ICSD-3 at this point. And that the kind of big bar in the middle, sort of that's right over the deeper colors, is sort of the proportion of folks that we would identify in this sample of 75 who are objectively sleepy, who have a mean sleep latency below 8 minutes, okay? And then each of the other columns is what happens when we add additional data. So the MHA is that what we call it the multimodal hypersomnolence assessment, because we needed a name for it. And basically what that means is an abnormal amount of sleep when we let them sleep ad libitum. So they slept more than 11 hours. They had abnormal pupillometry, or they had a grossly abnormal psychomotor vigilance task. And the main take-home point is each one of these additional ancillary measures helps you identify more people than you would have just with using the MSLT. And then if you combine just these three tools, you more than double the number of people you will objectively identify as having hypersomnolence this way. So I think this underscores the fact that there are some limitations to the technologies that we have and that we employ in the practice of clinical sleep medicine. And if we don't sort of look, we may be missing a lot of problems that people really do have. So to kind of transition the talk a little bit, these findings sort of beg the question. So if there are these substantial limitations in the methods that we have that we use to categorize non-cataplectic CNS disorders of hypersomnolence, so things like idiopathic hypersomnia especially, then could there also be changes in brain function or activity that are associated with hypersomnolence that may cut across different diagnostic boundaries? So in other words, if there are problems, the way that we've drawn the boundaries in and of itself, maybe the pathology itself also can cut across those boundaries simultaneously. So the last bit of data I'll share is information or data from another study that was funded in part by the ASM Foundation, as well as some other funding sources. This was actually some of my K Award work with NIMH. So we were looking at sleepiness, broadly speaking, especially in depression. So for those of you who aren't familiar, one of the things we love to do at the University of Wisconsin is high density EEG sleep studies. So this is just an example of this. Now, none of the other data I'd shown you was high density data. This is obviously used mostly for research purposes, although it could be used clinically if need be. It's the same general technology of measuring EEG activity at the level of the scalp. But here we use a 256 channel net compared to the typical sleep study montage that we might do on a polysomnogram. And then we let, in this study, people sleep ad libitum, wearing this high density EEG cap. And we were able to look primarily at, we were mostly interested in slow wave activity. So as being a really important part of the restorative aspects of sleep, and also tied potentially to sort of daytime sleepiness, sort of broadly speaking. And the study itself actually ended up having 4 groups. So it was a 2-by-2 table of people with and without depression and with and without hypersomnolence. So what that means is we had a healthy comparison group with no depression, no sleepiness, and none of these folks were medicated either, just to be clear. We also had patients with depression who met DSM-5 criteria for hypersomnolence disorder, as well as folks who were depressed, but also did not meet criteria for hypersomnolence disorder. And then we had another group that was recruited actually from our clinical database of people who had high density EEG sleep studies with no medications, who were not depressed, like per their chart review, if they had a Beck or some other measures in place. So we could say these folks did not have depression, but they were hypersomnolent as well. So the main take-home points, just to kind of hit the highlights, are across the middle panel here, we see what we call typical topography for slow wave activity. So when we take that 256 channel data that's sort of spread out over the scalp, we can plot heat maps so we can see where slow wave activity is highest compared to other parts of the brain. And sort of very typically across all of these patients, you see more slow wave activity in the frontal part of the brain. That's not an uncommon or unexpected finding. But what was really cool, the pattern that we saw that was really intriguing, was if people had hypersomnolence, they had reductions in sort of bilateral central parietal slow wave activity, regardless of whether they had depression or not. But if you were depressed but didn't have hypersomnolence, you had a different pattern of reduced slow wave activity, more in frontal brain regions, kind of in the midline. So there was a relationship, not surprisingly, between subjective daytime sleepiness and these reductions in central parietal slow wave activity. And then we applied something called source estimation. What this does is it's basically a mathematical way of trying to understand where specifically in the brain, not just at the scalp level, these reductions in slow wave activity may be emanating from. And we found the source that we found was sort of along the somatosensory cortex and the supramarginal gyrus, and also just a little bit of the transverse temporal cortex. So, and it's what's really interesting about this region, at least to us, is it was more prominent on the left, but also overlies the insula, which is one of the main sites of, we think, slow wave generation, broadly speaking. So it makes a lot of sense that that might be the area that we see these reductions in slow wave activity in persons with hypersomnolence, again, regardless of whether they have depression or not. So these types of projects have really, I think, helped me form a lot of the ways that I think about both the patients that I see and the research that I do in hypersomnolence. And really, a lot of the work that we do in the lab focuses on trying to take more of a phenotypic approach to hypersomnolence. So thinking about diagnosis, certainly clinically, but also thinking about what are really the complaints that people are having in terms of their hypersomnolence, sort of broadly speaking. Is it a long sleep time complaint? Are they having trouble staying awake, et cetera? And then the ultimate goal of what we'd like to do is to try to connect different, especially objective measures or facets of hypersomnolence to specific physiologic changes in the brain. So either EEG activity or pupillometry or whatever the measure would be, because that may help us understand and identify treatments that may work better for people in the long term. So this kind of thinking is not new. These are the kinds of things that I think are also consistent with things like the research domain criteria, which is an NIMH strategic initiative, precision medicine approaches. Also, all of these things kind of are sort of, I think, sides of the same coin. And ultimately, there's a question of like, if treatments can be developed targeting some of these transdiagnostic findings in persons with hypersomnolence, can they benefit a number of people across different diagnoses and disorders? So in sort of closing, in terms of take-home points, I hope that you guys can appreciate that patients don't always fit into neat nosological categories, no matter how well we define them, and that relying on the multiple sleep latency test really is the sole way that we can objectively measure sleepiness in sleep medicine is probably going to be problematic for a lot of folks with significant hypersomnolence. And oftentimes failure to identify pathological hypersomnolence in folks who do not have narcolepsy type 1 and sort of don't have cataplexy may be, for a few different reasons, probably the most important reasons are that hypersomnolence is multifaceted, so there isn't one single measure that can sort of capture it all. And that we oftentimes, at least in the practice of sleep medicine, really aren't using all the tools that we might have that we could develop as a field in our toolbox to measure and quantify sleepiness. And then I hope the other take-home point that you glean from today's talk is that really the changes in brain function, sort of how it works, may actually cut across a lot of these diagnostic boundaries. So sometimes we have to suspend our diagnostic boundaries and think about these findings as potential treatment targets, regardless of diagnostic category. So with that, I'll kind of wind down. I want to just take a moment to thank a number of folks. So obviously, I want to thank my department, members of the Wisconsin Institute for Sleep and Consciousness and Wisconsin Sleep, all my clinical and research colleagues, both at UW, and then also sort of broadly, it's been a wonderful time doing research in this field, and I absolutely love doing it. And then obviously all the members of my research lab as well. I want to thank the individual sponsors of the research because all of these things could not be done without sort of their support. And sort of with that, I want to really extend an especial heartfelt thank you to the ASM Foundation. So as Vanessa had mentioned, the ASM has been supportive of our research for a number of years and has really been helpful to me along sort of my developmental trajectory to kind of where I am now and helping me sort of learn about sleep medicine and become sort of the researcher that I am. So I owe a great deal to the foundation. So when they asked if I'd be willing to give a talk, I said, absolutely, of course. And so the ASM Foundation does so many great things for our field. And I urge people to think about the foundation when you're thinking about giving. And then also, if you're interested in research, certainly applying for the awards that they put up, because they really do, I think, ultimately help advance our field. So with that, I want to thank you for your time and attention. And then if we have time for questions, I'm happy to try to answer them.
Thank you so much, Dr. Plant, for the great presentation. We did have one question come through, and probably the only one that we have a chance to be able to go through. So it's a two-part question. Which lab can you send CSF hypocretin? And then the second question is actigraphy paid by insurance?
So those are both great questions. In terms of the question about CSF hypocretin, so there is a commercially available lab in the US at the Mayo Clinic, which has been around now. It's been active, I think, for about 3 years or so. So that's where it can be a send-out lab. Some labs also independently will generate their own. It's a radioimmunoassay, but it's a lot of work to do that. So if you do not do that at your local hospital, Mayo Clinic would be the place to send the sample. And you can go to their website and contact them with questions. And then in terms of, is actigraphy paid by insurance? That is a tricky one, right? So it really depends on the insurance, oftentimes not, especially if it's bundled with PSG and MSLT. We think it's really important to do because it can help identify, first of all, if people are getting enough sleep coming into the sleep study to give you an accurate finding, but then also it can identify pathology and tell you really important things as well. So we just kind of, we do it and eat the cost, but that's certainly we recognize an issue for getting it sort of more broadly.
Thank you for answering those questions. Well, we are at time. So again, thank you, Dr. Plant, for taking the time to talk to us today. And I just want to also thank everyone who participated in today's webinar in our first ever Sleep Grand Rounds. So today's webinar, there will be an email sent out to everyone with instructions on credit claiming. So this webinar is approved for 0.75 AMA PRA credits. And the next ASM Foundation Sleep Grand Rounds is scheduled on November 8th at 12:45 Eastern Time. And that webinar will focus on the management of sleep and diabetes. Additionally, I welcome you to view upcoming ASM and ASM Foundation webinars on current sleep medicine by visiting our event pages. Have a good rest of the day, everyone. Bye-bye.